I'm Christina Ferroni, a pancreas and hepatobiliary surgeon at the Massachusetts General Hospital, and I will be presenting case number 4. Case number 4 is of a 36-year-old gentleman referred to the Massachusetts General Hospital for evaluation of a pancreatic cyst. The patient had presented to an outside emergency room with a diagnosis of a kidney stone, and on evaluation of his kidney stone, he was found to have a pancreatic cystic mass. The patient denies any other symptoms of nausea, vomiting, weight loss, jaundice, dark urine, light-colored stool, or diarrhea. He otherwise felt very well after the pain of his kidney stone had passed. His past medical history is notable for hypertension, Hodgkin's lymphoma, obesity, shingles, and prostatitis. His medications include lisinopril and Lipitor. He has no known drug allergies. He was a former smoker but quit approximately 10 years ago and drank alcohol socially. His family history was negative for pancreatic adenocarcinoma or any other pancreatic lesions. On this CAT scan, you can see the 3.7 centimeter cystic mass in the tail of the pancreas. The lesion is at the very tip of the pancreatic tail, close to the splenic hilum. On CT evaluation, we were unable to make the diagnosis of an intraductal papillary mucinous neoplasm, mucinous cystic neoplasm, or other cystic lesion. The patient then underwent an MRI, which also demonstrated this cystic lesion. It was T2 hypointense, T1 isointense, and with some peripheral enhancement, as pointed out by the yellow arrows on the screen. Patient then elected to have an endoscopic ultrasound to further identify the pathology of his cystic lesions before proceeding with an operation. The endoscopic ultrasound did not identify a discrete mass. The pancreatic parenchymal abnormalities consisted of atrophy, diffuse echogenicity, hyperechoic strands, and lobularity. There was no mass identified either externally next to the cystic wall or internally within the cyst. A fine needle aspirate was performed in the area of the lesion seen on the MRI. The cytology demonstrated benign acinar cells only. No malignant or atypical cells were identified. Mucin was also extracted from the cyst. After a long discussion with the patient decided to elect for a laparoscopic distal pancreatectomy. The patient's decision was based on his age and that he did not want to commit to yearly imaging to follow this lesion. He also was concerned about the indeterminate diagnosis of his pancreatic cystic lesion, which also pushed him towards the operation. He underwent an uneventful laparoscopic distal pancreatectomy, which took approximately 90 minutes with minimal blood loss. A stapler was used to transect the pancreatic parenchyma, and a drain was left at the end of the operation. On this next slide, you can see the gross specimen that was identified in pathology. You can see a thickened cyst wall with mucinous and thickened debris within the cyst. Also, normal pancreatic parenchyma can be identified. On H&E section, you can see a fibrous wall. On higher magnification, you can see the thick fibrous septae. Most importantly, on high power magnification, you can see a cyst wall infiltrated with many lymphocytes. These lymphocytes help make the diagnosis of a benign pancreatic lymphoepithelial cyst measuring 3.8 centimeters. The patient had an uneventful postoperative course and was discharged on the evening of postoperative day 3. He did not have a postoperative pancreatic fistula. Due to the benign pathology of a pancreatic lymphoepithelial cyst, this patient no longer needs any follow-up.